taking Sarab away, but I guess I have to find forgiveness in my heart. Family first.
Yes. I miss my times in New York and Cornell dearly.
I was going to say you missed a bad year here, but I guess it was probably worse there than it was here.
Yeah, it would have been hard. Yeah, New York was tough.
It was definitely a tough year, but sounds like things in India are no better. Maybe worse.
I guess it will hopefully will curve down soon. It's a rise. Let's see. I'm just going to try to get the chairpersons on. Let's see. Just to Anil Arora. I don't see him. Let me just call the chairperson so they can just log in. Yeah.
Good morning,
Hi.
Dr. Brown.
This is Dr. Daswani. He is our gastroenterologist with us, and he's going to present one of the cases.
Sounds good.
And Bhushan, hi Bhushan.
Yeah. Good morning.
Bhushan is
Good morning, Dr. Brown.
also going to present one of the cases. He's a gastroenterologist, so we all work together.
Yeah.
Do you know? Have you met Anil Arora?
Me?
No, not you, Ravi.
Yeah, of course.
You know Dr. Bhargav from Delhi. So I was just curious because he's in.
Well, that I just know him because I trained Sandeep. I may have met him. I went there and visited. So, but there was a lot of people and only one of me.
Yeah. All right. Let me just call the chairperson so that we get them on.
Okay. What time? Isn't it late there?
It's 8 p.m. and this works well for India. Things are late in India. Yeah, I'm just going to call one of the chairpersons. Sorry.
A lot better than when I did a puzzle where they had me start at 9 p.m. my time and go to midnight.
Yes, Dr. Chaudhary. Right, so should be good. Let me just see. So are you guys like full-fledged back to normal with elective cases and stuff, or?
We should be. We were in the summer, and then we had a little, we've had a small second surge. It wasn't as bad in terms of death, but problem with COVID patients is they stay in the hospital forever. They don't die as much, but I just discharged someone yesterday who had a kidney pancreas transplant who had been in the hospital since the first COVID. So she spent a year in the hospital, trached and pegged with, recurrent pneumonia that would keep putting her back on the ventilator. We finally sent her to an LTAC yesterday. And so, the mean length of stay for a COVID positive patient in our hospital is, 21 days compared to the mean length of stay for an average admission is 5 days. So every one of those admissions counts as 3. And so our hospital has been at 98% census.
Oh my God.
And so we were at 50% elective cases for OR. For endoscopy, we're at full volume because you don't admit patients. It's only inpatient beds that are an issue. But, nurses are in short supply, getting ourselves back staffed up. A lot of people fled the city.
Wow.
It's going to be a bit. It's going to be a bit. But, we're back to like 90% of our pre-COVID endo volume.
Oh, wow.
And advanced didn't really has been, those cases don't change much. We have doing the same amount.
Yeah, in India, we either had staff getting COVID or something or the other. So it's been a real mess.
Good
Yeah.
evening, Anil.
Hi,
Welcome.
Dr. Anil Arora here. Hi.
Hi, Anil.
Hey there.
Hi, Dr. Robert. How are you?
Hi, Dr. Chaudhary.
Hi, how are you?
Welcome. You're looking young, Dr. Chaudhary.
Can you see me? I have to just to switch on my video. Hi, yeah, I'm there. Hi, such a pleasure.
Okay.
Hello, Dr. Brown.
Yeah.
Pleasure to listen to you.
I'm looking forward to speaking.
All right.
Good evening, Arora sir. Good evening, Chaudhary sir. It's a pleasure to see you again, sir. Thank you, sir.
Yeah, Ravi was with you, Dr. Arora, for 3 years, huh? Now
Yeah,
he's with us
So
now.
glad to see him.
Thank
Two
you, sir.
bright stars. You have been taking away all our bright stars, leaving us only with corona warriors.
All right. So anyway, I think we could, we have about 86, 87 people. We have about 270 registrations. So, I think they'll keep logging in. It's all 8:02. So maybe a couple of minutes and then we
Yeah.
can start. Dr. Brown, I know you must. Your talk will last how long? Like 45 minutes, 1 hour?
About 40. Yeah, it was 35 and then I added something in on pregnancy and immune tolerant, which I thought are important and new sort of controversial topics. So it might go to 40, but I left plenty of time. We'll be good.
Yeah. No, I just want to make sure that because we are fine. It's 8 p.m. So we are
Yeah,
okay. It's just you have to go back to your service, I guess.
I have till noon allocated for this.
Okay.
So we're
Thank
okay.
Thank you. Thanks for that. All right. So we can, let's see how much. Yeah, maybe.
If someone with their hand raised, I don't know if that means anything.
Yeah. Okay.
But they haven't typed anything in the chat box. They just raised their hand.
Yeah, it's we're still getting ourselves educated with how to use these tools. Have you guys? I see the emails on the Wild Cornell webinars. The grand rounds have been virtual. lately.
Yes, completely. As of last week, they removed starting, I guess, June 1, we can actually travel for business again.
Oh, wow.
Though international travel is frowned upon. Prior to this, if you traveled for business, you could not be I mean, obviously they can't prevent you, but there was no reimbursement for any. And if they had a meeting and you chose to go on it, one, you went on your own dime.
Right.
And two, when you came back, if there was quarantining, that had to come out of your vacation time. And the professional travel also had to come out of your vacation time. And so starting June, we can travel for business again. I did my first CME meeting, domestic.
Wow.
And I put it on my own personal time, but I just viewed it was time to go. Plus it was at a beautiful golf resort in Phoenix, so I couldn't say no. And then, people are starting to take vacations again. It's slowly getting back to normal. And the mayor says that all restaurants are going to be open to full capacity on June 1. And Broadway is going to open on September 1.
Oh,
They're going to go reopen the theaters. What it's going to look like, I don't know. But we have New York City, Manhattan has very good vaccine penetrance.
Yeah.
We're probably at least 60% have started vaccination. The problem has been that in the outer boroughs, particularly people of lower socioeconomic status, the vaccine hesitancy is high. But right now, it's now approved to vaccinate anyone 16 or older, no pre-existing conditions. I even got my son vaccinated. The college he's going to requires all students to be vaccinated, which I think is great.
Oh, nice.
Houston Methodist one of our sister hospitals now is requiring all patient-facing employees to be vaccinated. They're one of the first hospital systems that is requiring it for all patient-facing folks, which I think is good too. I'm like totally on board, but a lot of people have gotten worked up about it because
Everybody's keen on
the idea of mandating people do that, but I don't understand. We're required to do so many things to work in the hospital,
Yeah.
I don't see why it's wrong because if I was a patient, would I want to have an unvaccinated doctor or nurse taking care of me? And the answer is no, I wouldn't.
Right.
And
Right.
so if we wouldn't want it for our family members, it seems, unfair to put it on our patients without their knowledge.
Yeah. No, I agree. Well, I guess
But
we
it's
could start-
evolving.
Sorry.
Now
Yeah.
in New York, we have excess vaccine supply.
It's good.
And people are giving out beer if you'll go to the baseball stadium and get a vaccine. You get a vaccine and a free beer.
Good stuff. So we can start, I think now, I guess we have about 125 attendees. Sorry for that. We could get with the introductions and then start, I guess. Yeah.
Good evening, friends. Warm welcome on behalf of Midas Medical Foundation. And this is the second in the series of lectures to have update in gastroenterology. And we have today a great luminary in the field of hepatology, Dr. Robert Brown, who has co-authored the ASLD guidelines on management of hepatitis B. So we have to hear from him on hepatitis B. That is one subject which that is one problem which we face quite often in our practice in India. Along with him, we have also Dr. Gauradas Chaudhary, who has contributed many chapters on hepatitis B, and also Dr. Anil Arora, who is also one of the co-authors in the management guidelines formed by the Indian Society of Liver Disease for managing hepatitis B. He is also one of the co-authors. So we have two people, those who have written the guidelines. So with this brief introduction, I hand over the mic to Dr. Saurabh to introduce all the three persons, those who are here, luminaries. And I'm extremely thankful to all of them for taking out time and would be contributing here. Thank you.
Okay. Hi, good evening, everyone. Thank you. So we almost have 140 people. So it's fantastic to see everybody log in, and we can reach across continents now. And thank you, Dr. Brown, for joining us today. Just so you know, Dr. David Carlock gave the first of the series. So that was exciting. And you're the second. Thank you. All right, so I'll start introducing Dr. Brown and then Dr. Arora and Dr. Gauradas Chaudhary, who are here with us. Thank you, everyone. So Dr. Brown is the Professor of Medicine and Clinical Chief of the Division of Gastroenterology and also Vice Chair of Mentorship and Academic Development in Department of Medicine at Weill Cornell Medical College in New York City. He received his undergraduate degree from the Harvard University and then MD from New York University and MPH from University of California, Berkeley. He did his residency at Beth Israel in Harvard Medical School, followed by fellowship in gastroenterology and hepatology at UCSF, which is a fantastic liver center itself. He has co-authored over 200 peer-reviewed articles. He's the editor-in-chief of liver transplantation, and he has gotten several awards. And he was also, on a personal note, my mentor, as I was a liver fellow at Columbia University, and then I was faculty at Cornell, where I was working alongside Dr. Brown and learning from him every day. All right, and thank you, Dr. Brown. We also have Dr. Gauradas Chaudhary, who is a very senior, very experienced, eminent gastroenterologist and hepatologist in India. He has almost more than 35 years of experience as an educator and has immense experience in managing complex GI liver diseases. And he is currently the chairman of the Department of GI and Hepatobiliary Sciences at Fortis in Gurgaon. And he has been the past president of ISG, professor and had previously at SGPGI in Lucknow, and has had several awards and several book chapters, as my father mentioned. And Dr. Arora, who I have had a pleasure of interacting with many times, in fact, virtually, when I was at Cornell with his weekly rounds, and he is very, very interested in education, and liver and liver cancer is his area of interest. And as mentioned earlier, he has co-authored the INSL Indian Guidelines. He is the chairman of Department of Gastroenterology at Sir Gangaram Hospital, and he has undergone, he's received his training from AIMS, and he has authored several publications, and he has a great interest in viral hepatitis. And we look forward to having him today and hearing from him as we discuss some very interesting cases following Dr. Brown's talk. So thank you all for joining in. And I can see we almost have 155 people. So that's a good turnout. Thank you. Thank you all. And Dr. Brown, over to you.
Oh, well, thank you. I was beginning to be a little peeved that I was the second person, but if I have to be the second to David Carlock, I can live with that. So I'm trying to share my screen, but I don't see.
Yeah, what you have to do is open the PowerPoint in a window.
I haven't.
And then you share the PowerPoint itself, like not the screen.
Yeah, it says PowerPoint unknown. So I'll open one. If it's the right one, then we'll be good. If it's the wrong one, we'll have something different. Somehow this always works without a hitch until I try to do this. Open system preferences. Let me open my system preferences.
All panelists, it says. I think you should be able to share.
Yeah, it should be, but for some reason, where here's Zoom. Let's see if that works. Try it again. Let me also close the.
Yeah, I think you may have to reload in. You can
Reload
log out
what?
the Zoom link.
Okay, I can make you a co-host maybe if that works. No,
He's already
generally
made co-host.
he's a panelist, so okay. Yeah, this
If
text.
he's a panelist, you should be able to see the screen, share screen option in the center of the lower bar.
So
It's somehow saying that I'm not allowing access to Zoom, but I am allowing access to Zoom, and I don't know why that is. Where is privacy?
yeah, I think the privacy settings may prohibit sometimes.
Dr. Saurabh, do you have his slides on mail?
I'll email them to you now, and then maybe I'll sign out and sign back in, and we'll see if that works. In the meantime, I'll
Let's do that.
send them to you.
Yeah.
Yeah, Saurabh, if you have the slides, then
Then I can also play. That should not be a problem. If you can email me and then relog in, that could be one option. Yeah.
I'm sending it to your Cornell email because that'll take a file that's this big. All right, I'll be right back.
Well, sorry for the technical issues, everyone. We should get it sorted, or we'll have Dr. Brown talk and I can, share the screen. We can do that. Okay, I did get your presentation. So if you can't, I could do it, but I mean, you can try it from your end. You're mute, I think, yeah.
I'm going to try it one more time.
Sure, otherwise I can present it. You can just say next and I'll move forward.
Yeah, just present it because it's somehow not allowing me to share the slides. It's giving me a big exclamation point.
Okay, never mind. I'll just put it from here. That should not be a problem. So let me just yeah. So can you see
Yep.
it, right?
Can you put it into slideshow? Oh, there we go.
There we go. Yeah. So you can just say next and I'll move to the next slide.
All right. So let's go to the next one.
Okay.
And as I was saying, thank you for inviting me. I've had several trips to India before, which were really fantastic. And I look forward to being able to visit in person. And though it made me very unhappy when Saurabh left us, the idea of training people who then return home and advance the science of hepatology and liver transplantation. We have at least 2 transplant surgeons who are also in India. Really makes us, myself and Jean Aman, my surgical partner, really quite proud. Next one. So when I thought about the topic was pretty open, talk about hepatitis B. And so I thought I would concentrate on really the 2 hardest things, which is when to start and when to stop, and then touch briefly on choice of drugs, particularly the issue of TAF versus TDF versus entecavir. Next. So I developed this slide set in conjunction with Clinical Care Options, which is a CME company. And these slides are actually available on their website with actually a little tool if you want to have a HBV virtual consult that has the guidelines built in. I added to them, so some of them are my own. Next. So when we think about hepatitis B, we've gone from 4 categories to now trying to work with 3 categories in the new guidelines. And what that did was to try to take the E antigen positive and E antigen negative patients who had so-called immune active disease and put them into a single category, recognizing that they were the clear patients with who had inflammation, potential for progression, and indications for therapy. And then at the 2 ends, we have the immune tolerant disease, which I'm going to talk about later because it is the most controversial in many ways. And then the least controversial, which is the inactive carriers. I like to call them low replicative. These are patients in whom the immune system has viral control with low viral replication, less than 2,000 IUs, negative E antigen, meaning the absence of wild type virus with E antibody, and normal ALT. And these patients can have fibrosis because of their prior activity, but there's no data that says that driving them from 500 IUs per ml to 0 will change their disease state, though many think if you have cirrhosis, any viral load should be treated, and I am in that camp as well. Next. So if we think about immune active disease, the guidance document, and I think it's important that these documents are not set in stone. And the good thing about Hep B guidance is there's so many of them out there that if you can probably do whatever you want and find a guidance document that says you're okay. But I think what all of them agree on is, one, the primary driver should be viral load, because viral load is the primary driver in outcome. Where the difference is how do we decide on activity? Because we have not yet gotten to a point that, like HIV, we're going to treat all viral loads with a goal of doing lifetime suppression. Now, there are people who think that's a reasonable alternative, but it still is not the standard. And so if we think about it, the guidance has been meet the viral load guidelines and then have some evidence of progressive disease, either based on fibrosis or ALT elevation. And so immune active is defined by an ALT greater than 2 times the upper limit of normal, which is the old definition, or evidence of significant histologic disease, which is often defined by fibrosis stage on non-invasive markers, because we've moved away from biopsy. And then people debate whether we should be using the 2,000 IUs for both E negative and D positive, the 20,000 IU cutoff for both E positive and E negative, or where we are currently at the AASLD, which is 2,000 for E negative and 20,000 for E positive, recognizing that E negative patients are in general older, with more duration of disease and more fibrosis, and thus we should have a lower cutoff. Now, for patients who have advanced fibrosis or cirrhosis, generally the recommendation has been anything over 2,000, though some would say for cirrhosis, any positive viral load should be treated, and I would include myself in that group. Next. So, but what is 2 times the upper limit of normal? And we haven't agreed on what normal is. So if you look, there is in the United States, and I'm sure also in India, there is wide variation on where the upper limit of normal is. And that's in part because how we define what is a normal ALT. In the US, it's defined by blood donors who don't have hepatitis. But we don't have a BMI cutoff for blood donors, nor do we exclude diabetics. So it was recognized that many patients who were included in the normal ALT determination had NAFLD, or non-alcoholic fatty liver disease. And thus we needed to ratchet down the upper limit of normal. And we started with 30 in males and 19 in females. The American College of Gastroenterology followed up with 33 and 25. Where 33 came from, nobody knows. And the AASLD then reached a consensus with the ACG and the AGA that we would do 35 and 25. And thus, 2 times the upper limit of normal has been viewed by the AASLD and in our new guidelines as 70 for males and 50 for females, regardless of where the upper limit of normal is set in your lab. So in general, above that limit with the viral load, one should initiate therapy. Next. Now, immune tolerant HBV is an area of controversy. Now, these are mostly young patients, though increasingly we're seeing more people go 2 to 3 decades of life in the immune tolerant phase. They are always E antigen positive because they have wild type virus. They have very high viral loads, always over 1 million IUs, often over 10 million IUs. You see viral loads of 1 billion plus. They have normal or minimally elevated ALT or AST. And when we used to do a biopsy, they would have a lot of immunoperoxidase staining for core, but not a lot of inflammation. And so we have to define this group rigidly because typically they have not been a candidate for therapy, not because they're not at risk. We recognize they're at risk for HCC, even though they're not at risk for progressive fibrosis because they have no inflammation, but because they have not been included in clinical trials. We think the likelihood of seroconversion is close to 0. So once you start therapy, you are, in essence, barring changes in medical therapy, giving them a prescription for lifelong therapy. Next. So if you look, it has been recognized that for immune tolerant disease, we haven't had good recommendations. And so all three societies have said, well, if the viral load is normal, I mean, if the ALT is normal, we should not give therapy. But as patients age, the possibility that they may have ongoing fibrosis or an increased risk of cancer has led to some flexibility in each of the guidelines. The Americans being the least flexible, probably because we have the least experience, and saying only if we have fibrosis on non-invasive markers, particularly if they're over 40. Both the Asia Pacific and EASL saying use both fibrosis stage, age, and a history of complications, either cancer in the APOSL guidelines or cancer or cirrhosis in the European guidelines. So I think we have to take these patients and treat them on a case-by-case basis. And there are some people who are beginning to get to a point of saying we should just treat to viral load, and anyone above 20,000 IUs should be treated. But it is important that if you treat immune tolerant disease, you have to advise the patient that there is very little data on the rates of seroconversion. We know they're low, and that they likely will need very long-term therapy. Next. Now, the one exception to treating immune tolerant disease is in pregnancy. And for a long time, we have accepted mother-to-child transmission of hepatitis B at varying levels, which have changed. Initially, of course, before immunoprophylaxis, we accepted 90+%. Immunoprophylaxis with hepatitis B immune globulin and vaccination have reduced those levels, but mother-to-child transmission still occurred, particularly in those with very high viral loads. When we developed the 2016 guidelines, I felt very strongly and convinced a consensus of the group that in 2016, we shouldn't accept mother-to-child transmission if we could prevent it. And that would be critical to the WHO goals of hepatitis B elimination. And so we came down with the decision to recommend antiviral therapy in the third trimester to those with a viral load above 200,000. So this is 10 times higher than the 20,000. The only antivirals that have been studied were lamivudine, talbivudine, and tenofovir, generally started between 28 and 32 weeks of gestation, discontinued usually either at birth or 3 months postpartum. I tend to recommend 3 months postpartum due to the high rate of flares when it's stopped at birth. If they meet criteria for treatment, treating, and then this does not obviate the need for immunoprophylaxis with hepatitis B immune globulin and vaccine. Next. And this was because of this data that had been mainly from China, showing that if you were above 8 logs, the risk was 7.6%, above 6 logs, 3.2%, below 6 logs, 0. And so I wouldn't accept a 3% chance of passing Hep B to my child, and that's where we came up with 6 logs. Next. And other data, this is one of the studies using tenofovir that was published by Calvin Pan and colleagues in the New England Journal. Earlier data with lamivudine has similar results, showing that if you took immunoprophylaxis in the third trimester, you could reduce the rate to 0. And what you also see is that when you compare the per protocol to the intent to treat, intent to treat has much higher failure rates because people don't complete immunoprophylaxis. They get that first dose in the hospital, but often the second and third dose, particularly in rural communities, underserved communities, that 7% may be an underestimate of transmission. And even in the TDF group, there were failures related to people being non-compliant, either with TDF or with immunoprophylaxis. Next. So why do we recommend TDF over lamivudine in this situation? I think lamivudine is reasonable, but if you're going to use lamivudine prophylaxis rather than TDF, you have to stop at delivery because you don't want to give more than 3 months of therapy to prevent resistance. So now when we talk about treatment, the goal of treatment is obviously to prevent complications, cirrhosis, HCC, and death. We also want to prevent transmission, and we have all of these secondary outcomes that we look at to determine whether we're going to do that. That includes HBV decline, ALT normalization, E antigen seroconversion or S antigen seroconversion, and histologic endpoints. Next. But we have to recognize that for most of our patients, at least many, achieving these goals may require lifelong therapy until newer therapies develop. Next. So if you're going to use lifelong therapy, we have to choose it correctly. Next. So if you look in the US guidelines, we recommend either the nucleoside entecavir or the nucleotide tenofovir, of which there's tenofovir alafenamide and tenofovir difumarate, as the preferred agent because of high potency and high barrier to resistance. We no longer recommend lamivudine, telbivudine, or adefovir due to resistance. Pegylated interferon is still in the preferred therapies, but it is not preferred by many. I have not used pegylated interferon except for Hep B, Hep D co-infection in the last, I can't even count the number of years. I don't even remember the last time. I have treated a few patients with Hep B with interferon who didn't want to take long-term therapy, but the side effect profile and the low efficacy generally make it difficult. Next. So if we look, first of all, as nucleosides and nucleotides, it is important that all of these are adjusted for renal clearance. So for both entecavir and tenofovir difumarate, you need to reduce when the GFR gets down below 50. For TAF, which is formulated to have lower renal exposure, there is no dose adjustment ever, but there is no recommended dose for a GFR less than 15, but not on HD. So actually, I have a patient in the hospital right now who is on immunoprophylaxis for with Rituxan for that she's getting for a APLS crisis. Her GFR is falling every day. She's been on TAF. Soon I'm going to have to convert her from TAF to either TDF once a week until she goes on dialysis. Next. Now, when we think about treatment, I think the answer is that if you want to use TDF, which I don't use a lot of TDF, I use mainly entecavir and TAF because I think that TAF is a superior formulation to TDF. And so if I can, I'm going to use entecavir or TAF. If you're using all three, there are certain patients in whom entecavir or TAF is preferred. And these are people who are at increased risk of renal or bone complications, which would include older people, those with existing osteoporosis, chronic steroid use, or anyone with either a low GFR or a likelihood of developing a low GFR, which would include albuminuria. Now, to me, we included hemodialysis in this group, but to me, once you're on dialysis, it really doesn't matter. But there is probably more accumulation of TDF in patients on dialysis, and that may accelerate bone disease, which is another reason why TAF or entecavir may be preferred. Now, in choosing between TAF and entecavir in that situation, for most patients, it doesn't matter. But there are certain circumstances. Certainly, anyone who had prior lamivudine exposure, tenofovir is the drug of choice due to high rates of resistance to entecavir. Similarly, those with HIV, HBV co-infection should all be on tenofovir. And obviously, if their renal function is changing, it is easier to use TAF until their GFR gets to 15 because you don't have to keep changing the dosing. Now, in the US, there are certain drug programs that require the use of a generic. There is a generic for both TDF and entecavir, but not for TAF. And that is obviously a situation where entecavir may be preferred. And as I said, we have no dosing guidelines for creatinine clearance between dialysis and 15 mils per minute. Next. Finally, though, the data is coming out, particularly in pregnancy from the HIV pregnancy registry. We don't have data in decompensated cirrhosis, pregnancy, or children under 12 for TAF. There is no known safety concern. It's a lower dose, but they don't have indications in the label, though I can tell you that both in our decompensated cirrhotics and post-liver transplant, we actually use TAF or entecavir. We use no TDF because of the high rate of renal dysfunction. And I think the pregnancy safety data should be coming out soon. So right now, TDF is the preferred agent in pregnancy. I think that's going to change soon. Next. Now, one of the things that comes out very commonly is what to do with low-level viremia. So you put a patient on entecavir or tenofovir, and their viral load goes down, but it does not get to zero. And as our assays have become more and more sensitive, this becomes more and more common. Some of them are low quantifiable, and more common, it says less than 20, but detected. And traditionally, these patients were recommended for dual therapy with a nucleotide and a nucleoside. However, given the fact that there has been very low rates of reported resistance, in general, our new recommendation is, unless the viral load is rising, that there is insufficient data that you should change or add a drug. You should certainly ask about compliance. In my entecavir patients, I ask whether they're taking it on an empty stomach, which is important. For TAF, they have to be taking it with food, which is important. For TDF, it actually doesn't matter. Next. So now, I would say with the exception of pregnancy and immune tolerant, these have been very uncontroversial topics. When to stop therapy is probably the most controversial thing, with two camps, sort of forever, unless they have S antigen seroconversion, and not forever. And that's what I'm going to try to talk about, but I'm probably not going to illuminate. I'm just going to share my thoughts and where the data is. Next. So the first thing we have to say is we don't know what the optimal endpoints were. Traditionally, we used e antigen loss and seroconversion because this was a holdover from the interferon era, where that was the only endpoint we really could get to. And nobody wanted to accept the idea of lifelong therapy. So it does come down to what is the level of HBV suppression that we're willing to accept. If we want patients to be undetectable, it's going to be lifelong therapy for virtually all. If we're going to accept e antigen seroconversion, it's going to be lifelong therapy for about half. If it's going to be S antigen loss and seroconversion, it's going to be lifelong therapy for 90+%. So we need to figure out who is going to take therapy and educate them. When I start patients on therapy, I tell them it is a minimum of 5 years of therapy for all patients. And for most patients, it's going to be long-term therapy. But I tell them it is for the foreseeable future. And Saurabh can know I say that a lot. And what for the foreseeable future means is for a long time, barring changes in medical technology. And I always try to tell them, changes in medical technology will hopefully come. And our goal is to prevent complications till we get to curative therapy. Next. So for e antigen positive patients who don't seroconvert, we recommend long-term therapy. For those that do seroconvert to anti-HBe, if they have no cirrhosis, we can consider NA discontinuation after consolidation, and I'm going to talk about that, a minimum of 12 months, but that number also is controversial. Or you can treat to S antigen loss, recognizing that will be the majority of patients. If you want to treat for S antigen loss, it may be helpful to genotype your patient, since genotype A will get this in a considerable number, B and C way less, and D in between. For ASLD and EASL, it's 12 months. For a POSL, they say 12 months, preferably 3 years. I sort of draw my line in the middle, and I tell them at least 2 years after seroconversion. Next. Now, what is the likelihood that they're going to achieve that? E antigen seroconversion is anywhere between 20 and maybe as high as 40% at 5 years. But S antigen loss will occur in less than 10%. And if you look, the highest rate of S antigen loss in the TDF registration trial is probably due to the high number of Caucasian subjects with genotype A that were in that study. Next. So if you look at seroconversion, the worry is that they'll have seroreversion. And you can see that both age and period of consolidation matter. The patients who are older and have less consolidation period have a much higher rate. So you could tailor your degree of consolidation therapy to the patient. So those that are older probably need more than 18 months of consolidation. Those that are under 40 may need less. And you can see that data here. Now, if they don't have significant fibrosis, you can always restart therapy, but we prefer to avoid that. Next. So for e antigen positive, if they have advanced fibrosis or cirrhosis, I personally think that you have to treat forever or at least till S antigen seroconversion. If they seroconvert to E positive, I think if they're less than 40, you can consider stopping. And I must say, my young patients who rapidly seroconvert, those are the patients who have durable. And I've even had a couple who have S antigen seroconverted after we've stopped therapy. In older individuals, which less than over 40 is not that old, longer consolidation or S antigen loss. And obviously, because of the possibility of seroreversion, I monitor every 3 months for the first 12 months and then every 6 months. And this has been consistent. Even as I start monitoring my patients on therapy less frequently, I basically monitor my patients on therapy every 6 months. Next. So what about E negative? For the AASLD guidelines are treat forever. So those are easy. For the apostle and easel in the non-cirrhotic patients, there is some recommendation that you can stop therapy after somewhere between 2, 3, or some say 5 years of therapy. Next. And this comes from the fact that we're very good at suppressing HBV DNA in E negative patients, but we don't get S antigen loss. And so the likelihood of viral recurrence is very high when therapy is stopped. Next. And what happens when you stop is virtually everyone gets a return to HBV DNA. But then they follow several patterns. One is they can go back down and then be the same as what we would call the chronic carrier. What this probably means is they've lost enough of the ccc DNA that contains the pre-core or core promoter mutant that the immune system can keep it in check. Others return to their baseline state with E negative virus that does not produce E due to the pre-core or core promoter mutation, replicating at either the same level as before therapy or perhaps a lower level. And so some would say, of course, in patients who had mild disease, there's very little downside to letting this happen and then being able to stop therapy permanently in some of the patients, anywhere between 20 and 30%. Next. So if we look at the data, this really started with the Hbv Dna data in which patients were stopped after 5 years. We had very little data until this paper published by Tom Berg, in which he stopped therapy in E negative patients who had had TDF for at least 4 years, and he randomized them to stop therapy. And you can see at baseline, virtually all of them were suppressed. After 8 weeks, virtually all of them were replicating. And then over time, a proportion had S antigen loss up to 19%, and 2/3 remained off therapy because their viral load was less than 2,000 and their ALT remained normal. Now, you could look at this one of two ways. First, that up to 2/3 of your patients could stay off therapy for a long period of time, but they will replicate. And if they won't accept replication, they've gotten so used to being negative, you should know they won't. 2 is they're all going to flare to above 2,000. So if they have advanced fibrosis, you have to do this with caution. And then finally, you have to decide how much you're going to change your practice based on studies of 20 patients. So this study had 21, Hbv had 27. So that combined is 48 patients. I don't know if that's enough to change the way I practice medicine. Next. And you can see that this is not without risk. Here are a couple patients who had flares of their ALT up to 1,000. And so you have to be ready. The patients have to be ready to be monitored and to go back on therapy. Next. What about Asian patients in whom therapy was stopped? Because these were largely Caucasian patients. And so these were E negative patients who were on entecavir or tenofovir for over 12 months, who had compensated disease, once again randomized 2-to-1 to either discontinue or continue. Next. And you can see that similar data, maybe a higher proportion retreated, up to 38% retreated, but about 1/3 of the patients here staying off therapy because they had a sustained response, and 20% having sort of an intermediate response where their ALT was normal and their viral load was a little higher, but they didn't go back on therapy. So this would be the low end, and Berg would be the high end. So what I tell my patients is it's somewhere between 1/3 and 2/3 will be able to stay off therapy. Next. And when they predicted who would have flares, you can see that males were more likely than females, those that had previously been treated, and genotype B and C were more likely to do this, though in the multivariate model, it was a high viral load and males who were more likely to have flares. Next. So for E negative summary, we have advanced fibrosis or cirrhosis, treat indefinitely unless they have S antigen loss, but this is very unlikely. There are some withdrawal strategies, but you need close monitoring. Next. So what have I tried to tell you over the last 40-ish minutes? One is you need to know your fibrosis stage and never stop treatment in patients with cirrhosis. Fibrosis stage in my practice is all determined non-invasively, usually with elastography and serum testing. If they're E antigen positive, E antigen seroconversion is a reasonable goal, somewhere between 12 and 3 months of consolidation therapy. Quantitative S antigen may help you if you want to determine who's likely to get to S antigen loss and seroconversion, because if you have someone who has had a dropping quantitative S, I would tend to treat those to S antigen loss. In E negative, most patients should be on therapy indefinitely, certainly those with moderate to advanced fibrosis. And if you're going to stop, at least 3 to 5 years, need to monitor closely and prepare the patients that, one, they will get virologic recurrence universally. Some will have flares, and anywhere between 1/3 and 2/3 will need to go back on therapy. Next. Thank you. I'm looking forward to doing the cases, and I couldn't look in the chat box and the Q&A while I was talking, but answering those questions as well. Here's my contact information. If you have any questions, want to send me an email.
Great. All right. Thank you so much for that. That was fantastic. Great. Yeah, right in time. So thanks, Dr. Arora and Dr. Chaudhary were here. Should we do some of the case discussions, or what do you guys, Dr. Arora, Dr. Chaudhary, do you think we should do the question and answers, case discussions?
Sure. Please go ahead.
I'm sorry.
Yeah, I think excellent presentation by Professor Brown. I think before we initiate the discussion, it is important we have the prototype cases to start with, and then we can switch on to the discussion.
Okay.
Sounds good.
All right.
Yeah.
So let me just have the first presentation here. Okay. So these are some cases, some sort of challenging scenarios for which we would love to have everybody's opinion. Yeah. I'll hand over the mic to Dr. Shrikant Makeva here. Yeah. Okay.
Dr. Brown, it was quite interesting lecture, particularly data on off-therapy data, which is very exciting. You had elaborated the entire thing very clearly, and I think it will help in patient management. I'll start with the first case. Let me share our data at Midas. In the last 3 years, we have seen about 691 chronic Hep B patients with the mean age of 44.7 years. And it's a predominantly male, 73% as compared to female, 27%. So 3 out of 4 patients are males. About 40% of them, they are cirrhotics, and 4% had liver cancer. So we had sizable numbers, around 200 to 225, in spite of lockdown, which was there for the last year. We had sizable numbers of hepatitis B at our institution. I start with a patient. He was a doctor, who himself was a doctor, 50-year male, who presented in last year, January, with hematemesis, and was diagnosed to have portal hypertension, underwent banding for his varices. He was diagnosed as cirrhosis. His weight was 56 kg and BMI of 22. His LFT showed a bilirubin of 2.1, albumin little low, 3.2, enzymes, as you said, 2 times elevated, INR of 1.1, and electrolytes were normal. So we have a patient who presented with cirrhosis, alcohol intake not significant, social drinker, 2 to 3 times in a month. HbsAg was negative, hepatitis C virus was negative. So once alcohol BC negative, we went ahead doing the autoimmune profile, which was again negative. The KF ring and urinary copper was negative. Gamma globulin was 1.5 times normal. We got core antibodies, and which were positive. So the next step, once the core antibodies were done, was Hbv Dna Pcr, which was 50 IU, that is 300 copies per ml. So basically, we were dealing with a patient by definition of who was HbsAg negative, but PCR positive. So it was an occult Hep B infection. So we had a further evaluation of the patient, whether the patient had co-infections in the form of HIV, HCV, Delta virus, all was negative. His anti-HBs antibodies, which are protective antibodies, were less than 12, 8.73. E antigen was negative, anti-HBe was positive, suggestive of a mutant virus rather than a wild virus. Fibroscan showed a range of cirrhosis. The CT scan was also done to rule out hepatic venous obstruction, revealed CLD with dilated portal vein and splenomegaly. Liver biopsy, patient was not willing, and we were also of the opinion that how much will it be useful. So a diagnosis was patient had chronic liver disease, cirrhosis, Child's B, with portal hypertension. The etiology, one possibility was patient had hepatitis B for the long time, and with the long duration of hepatitis B, the surface antigen has been lost. The second possibility was that the patient had cryptogenic cirrhosis with incidental occult hepatitis B infection. I would like to have the opinion of Dr. Brown and the chairpersons on this, any additional things, and what is the thinking? Then we can go to the questions.
This is uncommon, but not unheard of. And we have the same debate. What I think we'll all agree on is that it's unlikely that the duration, that the fibrosis developed in the setting of this very low level HBV replication. And that either he had ongoing Hep B and that late in his course, he had S antigen seroconversion after he already had cirrhosis, or that he has some other form of liver disease in this situation. That I think most people would agree on. But deciding which it is without doing a biopsy and looking for how much immunoperoxidase staining is unclear. I would tend to treat him I would repeat the viral load, and if it was positive, I would tend to treat because I think any positive viral load you want to avoid, though I would be very pessimistic that I'm going to change the course of his disease as much as if he had been replicating at a high rate.
Dr. Chaudhary and Dr. Arora, any
I
comments?
would entirely agree with Dr. Robert. You see, it's an uncommon situation, very uncommon situation, to the extent that, I think one of the issues of debate in Indian practice is that when we screen patients for hepatitis B surface antigen and anti-HCV, and we find that they're both negative, how often would we go in for a total IG immunoglobulin anti-C, and how often would that necessarily be an indicator for ongoing hepatitis B infection? And then getting the DNA in low levels, I would agree that it fits into the shall we say, the label of an occult hepatitis B infection.
Yeah.
One of our PhD students, we did one study of looking at what is so-called occult cirrhosis or cryptogenic cirrhosis. And we did find that a proportion of them, this was way back in the 90s or so, that, one could find those Shikata cells or the peroxidase positive cells and some degree of hepatitis B DNA. But the numbers were small. But having said that, those were days when hepatitis B was far more common in India. Now things have changed a bit. So I think that's a very interesting case that you put forward, Dr. Mukherjee. For lack of anything better to do, I would entirely agree with Dr. Brown that, I think giving him a antiviral treatment for hepatitis B would possibly be the ethically right thing to do, given the fact that he already has child's B liver cirrhosis, and whatever little good that it does, it would be fine. It would, however, be important to look at the clinical course of how the cirrhotic liver behaves to decide on what would be the next step, that is whether one should think of liver transplant or not, at what stage. So that's it.
Anil, you want to comment?
Yeah, Saurabh, if you look at this case, there are two major issues. One is, why are we saying this as occult HBV? For two reasons. One is, first, after HBsAg was found to be negative, you look for IgG type of total anti-HBC antibody, which was positive. So based on that, you look for Hbv DNA. Now, Hbv DNA in patient with cirrhosis is a dynamic entity. So the reason for our labeling this as occult HBV is a single isolated reading of Hbv DNA. I would agree with Professor Brown that you can never diagnose occult HBV with a single isolated reading of Hbv DNA, which is a dynamic thing. To say that this is an occult HBV, first and foremost is we must repeat Hbv DNA. And if it is either increasing, then only we should start treating a situation like this. That is the first thing. Second issue is, if you look at the positivity of core antibody in Indian scenario, if you look at the blood bank data, 35% of Indian population will be positive for core antibody in the blood. So does it mean all of them have chronic infection, or they have been exposed to hepatitis B in the past, or they deserve treatment? Secondly, in a situation like this, the relevance of Hbv DNA is that it is the only treatable factor in a situation like this, especially if it is an advanced cirrhosis. So the baseline presence of Hbv DNA will also depend upon your own prevalence of hepatitis B in the general population, which is pretty high, especially if you look at the IgM core antibody or IgG core antibody. And if Hbv DNA is rising on repeat attempt, then I can think of treating him with Hbv, not otherwise.
Yeah, the patient had enzyme elevation And decompensated cirrhosis. So we started him on tenofovir because decompensated cirrhosis, entecavir can lead to lactic acidosis. And there is, as rightly said, that there is no data of tenofovir adafenamide in decompensated cirrhosis. So few questions. How common is occult hepatitis B in patients with chronic liver disease in your practice? Dr. Brown, please. There will be difference in your practice and our practice. So we have the views of both the sides.
I think it's really uncommon. And as highlighted, core antibody positivity is common and should not be interpreted as occult hepatitis B unless you have at least, I would say 2, probably maybe 3 positive Hbv DNAs and no other cause for chronic liver disease. I've seen patients labeled as occult Hep B who have negative DNA and simply a positive Hep B core, and that's almost never the case. But I do think that it does exist. There is that rare pre-S mutation, which is a fairly replication deficient virus, so usually has low viral load. Though I think for the most part, as I highlighted earlier, the patients progress likely not with occult Hep B, but progress with active Hep B and then seroconvert when they sort of have burnt out cirrhosis.
Yeah. In fact, patients who had suffered from Hep B and recovered may have acute Hep B, would have antibodies to core and may not have a PCR positive. Dr. Anil and Dr. Gordas, what is your experience?
One important message from here is it depends on, as I mentioned earlier, about the baseline positivity of HBsAg in the general population and the core antibody.
Yeah.
Second important is what is the way you are looking at the HBsAg quantitative assessment of the HBs antigen as well as the Hbv DNA. What is the sensitivity of your test? So if you are having an ultra sensitive test which picks up as low as say 3 to 5 international units of Hbv DNA in the blood, then obviously if you look at the word data on occult HB, it is variable from anywhere from 1% to 80% depending upon your sensitivity of the test. So what is important is that first of all, you know what is your level of sensitivity in your own labs, what is the baseline prevalence of HBV in general population, what is the baseline prevalence of core antibody in the general population, and then what is the relevance of testing. As you rightly said, one way of looking at HBV occult is that it is possibly one way of immune system taking you over your liver, in which it is not enough to eradicate the virus, but it is good enough to prevent the ongoing damage. So does it need a treatment or not? We are still not sure.
Can I ask a question?
Yeah.
So I remember that, when this lady worked with us and did this study on occult infections as a part of cryptogenic cirrhosis, the blood tests were obviously considered to be inadequate, and therefore we did insist on liver biopsy. And we all understand the importance of liver biopsy. Post-liver transplant, you have so many surprises coming on with the liver that's removed. And there we looked at using molecular probes or special immunohistological staining to prove the presence of hepatitis B before we labeled it as occult, because otherwise it does become very difficult. And we thought that time it was not uncommon in India because we had a lot of, shall we say, people with normal BMIs getting cryptogenic cirrhosis for no unknown reason. But that was way back in the 90s. Right now, the hepatitis B has come down, and then to get this combination, Dr. Mukevar, which you have given, I mean, it really taxes me as to how I would go. But I want to ask Dr. Arora if he would take off his researcher hat and put on a clinician's hat. And if you were confronted with a person with a child's P cirrhosis, doctor, and his BMI is not high, and his child's D, and there was some evidence of hepatitis B DNA even in small amounts.
Yeah.
How difficult would it be to convince him and yourself not to start antiviral therapy at that stage?
As I said, if I'll repeat the Hbv DNA, if it is detectable at any range, I'll put him on. I'll not go by one isolated reading.
Okay, that
Hbv DNA is good enough for me to initiate the therapy because there is nothing else to offer in him.
absolutely.
As far as the sensitivity of the assays is concerned, most of the places, the card method or immunoelectrophoresis or chromoelectrophoresis is the method which is used. And that is also, we are also using it commonly. And the amount of HbA1c picked up is 0.5 nanogram, which is almost like 100% sensitivity and around 99.5% specificity. So, I mean, it's quite good sensitivity specificity as far as picking up of HbA1c with the routine which are available tests with us. What is the risk of progression of such patients? Any thoughts on that?
In
Does
fact,
it lead to cirrhosis and HCC?
as of now, if you look at cirrhosis and HCC, there's a good data available in patient with hepatitis C related cirrhosis of the liver with HCC with an occult HBV. There are different studies which give you conflicting results. As of now, the consensus is that presence of occult HBV in patient with HCV related cirrhosis and NASH related cirrhosis does not aggravate either the fibrosis or it does not contribute to increased incidence and prevalence of HCC.
Okay. Dr. Brown, you want to add something? Does it lead?
I mean, we know that viral load is the driver of outcome. So I think it's low, but not zero. The problem is that cirrhosis is a huge risk for HCC. If we remember from the REVEAL data that the presence of cirrhosis, increases the risk of HCC tenfold, just like high viral load. So this patient is still at substantial risk for HCC. I don't know if lowering the viral load from 50 IUs to 0 is going to change that risk that much.
Yeah.
So the reason you developed hepatocellular carcinoma in patient with cirrhosis related to HBV is twofold. One is that the virus gets integrated into the host genome, and secondly, it has a propensity to produce proto-oncogenes or stimulates the antigens which have a propensity to develop HCC. So I'll agree with Dr. Brown that in both the scenarios, antivirals are not going to be of use unless you get rid of the virus infected cells by stimulating the T cell response, which will get rid of it. Short of that, antivirals are not going to change the effect of HBV reduction in terms of our DNA in the blood by simply giving nucleic acid therapy, the only therapy which we have at the moment.
And we'll go to the next question. Will you do liver biopsy before treating, Dr. Brown? What is your policy in such patients? Is decompensated cirrhosis?
No, I think the role of biopsy is when the diagnosis is unclear. So oftentimes what you have in a patient like this is the ANA is also positive at some low level, or the immunoglobulin, the IgG level. The main reason to do a biopsy is to exclude another treatable cause, which is usually autoimmune hepatitis. If the ALT was 200 and not 70, I would say there would be an indication for a biopsy because I'd have trouble understanding an ALT of 200 with an Hbv DNA of 50.
So, yeah.
But other than that, no, I would just start treatment and treat portal hypertensive complications. Hope that the patient was going to get better with antiviral therapy, but assume that they were not and think about when they're going to need a liver transplant.
Yeah. So I think this is answer. Would you treat this? And majority of us feel that we should treat these patients, and how long is, I think, lifelong or till he gets transplant. I'll have a short presentation of 5 minutes before we.
There are like 20 questions also.
So which situations you get HbsAg negative but PCR positive? It's in the window period, that is before the HbsAg appears. But in clinical practice, that's within 10 days, the jaundice will come. So that's the window period is one. The second is after acute hepatitis, the HbsAg disappears, but the viral particles persist for years in the blood and liver. And the third situation is that the patient has chronic infection, long-standing, and with the over years, HbsAg disappears, but the virus particle persists in the blood. So the window period is really not an occult infection. It's mainly between acute and chronic, and in clinical practice, mainly chronic. This is to show you the data that even after 5 to 10 years after, the virus particles are there in the blood or liver. What is occult infection? HbsAg negative by the current assays, but positive DNA in the blood or liver. Usually it is a low viral load and has, the most important is it has got a replication component. The classification can be either a seropositive when you have core antibodies and surface antibodies which are protective, or it can be seronegative where only DNA is positive, but this is supposed to be of less infectious, and the clinical importance is not very known. Now, why does the occult infection occurs? And this is because of two reasons: integrated Hbv DNA in the hepatocytes, and the long life of hepatocytes makes it a chronic infection, difficult to treat. And there are various factors like genetics factor. The gene, its increased level would prevent the replication of the virus. Methylation of ccc DNA results in less replication. And the most important, as has been said, that the T cell, memory T cells, get stimulated by the low antigen, leads to rapid expansion of the effector cell. Whereas in overt infection, because of high viral antigen load, the T cell dysfunction is there and there is no memory cell. And the methylation and the other genetic factors are not there. So apart from T cell, the B cell immunity and innate immunity is also responsible. The prevalence depends upon the geographical area, the methods tested, and the group tested, but it's more in high prevalent area than low prevalent area. The 32% of cryptogenic cirrhosis, around 40 to 75% of SCC, the anti-HBC antibodies have been detected. Hbv DNA in liver, this is very interesting Italian study. They have operated 90 patients where taken the liver biopsy. 16% of the liver biopsies showed Hbv DNA in the liver, and they didn't have liver disease. So this is the prevalence of Hbv DNA. The clinical impact is mainly in the transmission of the virus and the reactivation when they get chemotherapy. Cases of fulminant hepatic failure, there is an association with hepatocellular carcinoma. The Japanese study said once you have a positive DNA, your chances of developing disease after 5 years in a patient with cirrhosis are twice more at 5 years and literally 100% at 10 years. So it definitely adds to oncogenesis. Antiviral therapy is not recommended in alone patients with OBI. Risk of SCC is less without HbsAg, and sterilizing cure, eradication of CCC DNA is not possible with the present available drugs. So thank you very much for this listening.
Okay, thank you. Should we, I think that we do have a lot of questions, and I know, Dr. Brown, you have to leave in 10 minutes. What we could do is get through some of these questions first. Do you want to, okay. So, Mr. Kunal Vyavare is asking, current role of quantitative HbsAg in guiding treatment?
He seems to ask two questions. One is about the use of interferon. I think if you're going to use interferon, quantitative HbsAg becomes much more important because it allows you to stop interferon after 12 weeks in those that are unlikely to respond. If you're using nukes, it is less useful, but will predict to a certain extent who is going to have a higher frequency of losing S antigen. But the question is, do you want to measure S antigen in 100 people to predict that small percentage who are likely to lose S, or are you just going to do it on clinical grounds? So quantitative S is available in the United States. It took a long time to get here, but it's infrequently used.
Right. And on the same lines, how beneficial is PEG interferon as sequential therapy? I guess you showed that in your slides, the data.
Yeah, I think the answer is that it makes a lot of sense. There was a lot of excitement about doing it, but it doesn't seem to add much.
Mm-hmm. Okay. We have HbsAg in a 3-year-old child on rituximab for ALL, had flare, weight 17 kgs. Pediatric patients. Any comments from the panel? Yeah.
I think all patients treated with Rituxan need to be prophylaxed. Lamivudine might be the treatment of choice there because there is a pediatric formulation, particularly if they weren't replicating before therapy. You know, in those patients who are not replicating, core positive, for example, probably one place where lamivudine probably is sufficient. Once they've flared, I would use tenofovir, for which I think there are pediatric formulations due to the HIV use.
So Dr. Jayanti Venkatraman is asking, in few cases, hepatitis B surface antigen is negative, but anti-HBs does not appear. Any particular reason on withdrawal of NUCs, there is resurgence of Hbv DNA? Okay.
This does happen on therapy. You lose surface antigen, you don't develop surface antibody, and then you're sitting there deciding what to do. It's rare because surface antigen loss is rare. I've done all sorts of things. I have vaccinated them on occasion. We've stopped hepatitis B therapy on occasion. Most of them have stayed negative. And so I don't think you lose surface antigen without immune reactivity to the virus, whether it's cell-mediated or low-level antibody. It also depends when you measure. So surface antigen, whether it's from surface antibody, whether it's from vaccination or natural clearance, wanes over time. It's why so many patients have isolated core. And so presumably they had antibody and it's waned. And likely if you stop therapy, they will, S antibody will increase. I have one patient in whom we've stopped therapy and he loves to measure his surface antibody titer. And it has, he's now 5 years off therapy and his surface antibody titer is sky high. And I think what it tells you is He has CCC DNA and integrated DNA. It's trying to get out there, but his immune system is keeping it in check.
Mhm. All right. One from anonymous attendee. Should treatment continued in a chronic hepatitis B patient with KPA value 30, 55-year-old male with E antigen negative, viral load undetectable for the past 3 years? I guess,
Anyone with cirrhosis, treatment forever.
yeah, right.
And then there's someone who said, is there a role for steroids in a Hep B flare? I think one thing we should lay to rest, there is no role for steroids in any aspect of Hep B therapy ever. Steroids are bad. You have to be my age or older to remember when steroids were used to prime Hep B prior to interferon. It was a terrible idea then. We didn't know it then, but now there's really no excuse. And certainly if you have to use high dose steroids or immunosuppression, prophylaxis should be entertained.
Mhm.
Yeah.
Right. When do we treat an immunotolerant hepatitis B patients whose age is above 30 years? Do we have to take DNA cutoff of more than 100,000 or 20,000 as an ESL criteria? I guess.
I want to hear my co-chair's opinion on that. I shared my opinion. I make a case by case determination.
Dr. Arora, Dr. Chaudhary,
Yeah.
any comments?
See, I have a very strong view on the utility of TAF. I think it is a drug which is dirt cheap in India. It has practically no side effects, and up to 10 years it has been used in patients with HIV without any substantial bone or the renal toxicity. Now, if you look at the relaxation of the indications as well as more inclusive usage of TDF and then TAF, especially in EASL, anybody who's more than 30 years, anybody who has comorbidity, concomitant HIV or HCV infection, metabolic syndrome, or fibroscan value of more than 11, these are the subgroup of the immunotolerant guys who need TAF. So I think what is wrong in monitoring them every 3 months with Hbv DNA, with fibroscan, with ultrasound, everything costs money. Why not then simply put them in a simple drug like TAF and then monitor them infrequently rather than spending so much of money? So I'll be more liberal in using and having more indication for using TAF in patients with immunotolerant, especially with all the indication given by EASL like extrahepatic manifestation, family history of HCC, comorbidities, and majority of these patients may have one of these. So I'm pretty liberal in using, telling the patient very well that they will require a long-term therapy. How long? Only time will tell us. So far as we have nothing more to offer, just to suppress the virus, because from the REVEAL study, there is a good data to show the higher the viral load, more likely it is going to get integrated. And there is a linear geometrical relationship between Hbv DNA load and incidence of HCC. So if we have a drug which is free of side effects, dirt and cheap, then why not use it?
Right. Oh, that's a good point.
Dr. Gaurdash, you want to?
I mean, I was
This
once
is a controversial issue. In fact, the EASL has suggested that more than 30 years, you can straightway treat the patient. And ASLD has said that you do liver biopsy, find out whether there is a necroinflammation, and then treat the patient. 40% of Indian Asians with high viral load, the biopsy shows fibrosis. So whether to investigate or treat empirically.
So I was once discussing with my students, residents, that why do ASLD and the European guidelines change so frequently? I mean, why do you have to revise it every 2 to 3 years? The reason is, and you can't actually say that, look, what I did was right then and it's wrong now, or vice versa. I mean, the basic reason has been that, okay, our understanding has deepened. But as Dr. Robert very rightly showed, some of the data is based on about 20 to 40 patients, very well done, well written up, shall we say, papers in good journals. But the fact of the matter is that the data is often not as large and robust on which to draw conclusions which can be extrapolated to very large numbers. But having said that, the issue is that there are practical issues. So when we talk about Hbv DNA loads, we often then think about the reveals the study where, you know, the DNA correlates with complications. And then when we look at the other part of the story, then we look at histology for inflammation, or shall we say, you know, ALT rise as a marker of inflammation. In practice, I would agree that what Dr. Arora was saying is fine. You see, once upon a time when we were using lamivudine, and I used a lot of it, obviously. I mean, we in fact saw the advent of lamivudine. Prior to that, we were using ordinary interferon 3 times a week. You know, we were ecstatic with lamivudine, but after 1.5 to 2 years, we found that there was a huge amount of resistance coming in. So the same mindset about worrying about resistance development is what we carried through when we had adifovir and then telbivudine and so on and so forth. Fortunately, the ones who have responded to tenofovir in my practice over the last about 8 to 10 years, I've indeed extremely uncommonly, I can't remember really more than 2 cases where resistance has developed to the extent that, you know, I've had to think of changing therapy. That renal functions or creatinine has risen is a different issue. I've had about 3 people who did develop renal problems at the onset, but development of resistance has been remarkably less compared to what we thought of, in comparison for that matter to entecavir. In fact, I think if you remember, Anil, when we had a lot of patients who had been exposed to lamivudine earlier on and we put on entecavir, in fact, we published a paper that I think about 30% developed resistance to entecavir in the next 2 years compared to, say, naive patients. So having said that, I would say that, look, here is a person with very high DNA levels. He might come back to you and throw the paper on your face that, look, I mean, high DNA levels are linked with HCC. How right or wrong would be to not offer him therapy for viral suppression? I think it's a very important point, which Anil has raised.
I think what I would say is I tell the patients it's not a question of if, it's really a question of when. And so one, you know, you have to tell them that the caveat is we have much less data on the rate of suppression with these drugs in immune tolerant. Some data that says that they suppress completely at a lower rate. And 2, that if their immune system at least recognizes the virus and they enter the immune active phase, they do have a higher chance of e-antigen seroconversion. And there is a downside to therapy if they are non-compliant. You know, if you stop taking your statin, the worst thing that happens is your cholesterol goes up. If you stop taking Hep B therapy, there are consequences. And so I think you have to just have that conversation and have compliant patients who are either going to stay on therapy or be monitored if they come off therapy.
Yeah, Dr. Saurav, I think it's an extremely important caveat that once you start the patient on antiviral therapy, after having told them all the limitations of therapy, most important factor is you have to tell them that it is a lifelong therapy. Right. Half of the time as gastroenterologists, we do not spend time with them. They go back, get an Hbv DNA after 6 months, see Hbv DNA plumbing down from say 10 lakhs to 5,000. They think it is a wonderful therapy. After 1 year, if it is nil, they will stop it. But we have to tell them what we are treating is HbsAg clearance, not DNA, which is going to get suppressed in any case. I think the more time we spend as hepatologists in telling them the limitations of therapy and our aim of trying to achieve an HbsAg clearance, which may be a distant dream, but this is what we have to offer. If we are able to...
There are, Anil, so there are trials of emtricitabine and the tenofovir in patients with immunotolerant phase for a period of 3 to 4 years, except that combination therapy has shown decreased in the viral load, but no benefit in terms of HbsAg clearance. And obviously these patients are asymptomatic. So there is no question of their inflammation and symptoms improvement. So overall, this problem is not being solved, you know.
Right. So just sorry,
let me ask you a question.
Sorry, sir. Just Dr. Brown, I understand if you have to leave, we totally understand. And we could just continue with Dr. Arora.
Before Dr. Brown leaves, can I ask a question which only he can answer?
Yeah, perfect, perfect.
Sure.
Sorry for that. Yes.
Dr. Brown, you know, we have been playing around with the same toys for more than about 10 years now. I think the only new chip on the block has been this TAF. And that too, I guess it's been almost 10 years for that as well. The question is, I know that the United States has very restricted entry of new products, and that's why it often comes a little late because of your FDA. And, you know, I have got a few patients who came all the way from Germany and Russia, and they seem to be now having available with them the genome sequence stoppers, you know, the Mercludex and so on and so forth. Any idea about where the research is heading? I believe there's a German research consortium who's working very aggressively, and these products are available in Eastern Europe, Russia, and Germany. Any thoughts about that?
I think that, I mean, both, you know, siRNA technology, you know, we were all excited about clevidine. It disappeared. And now I saw an abstract at EASL that people are studying clevidine again. I think that there is a lot of interest, but I do think we have to recognize that DNA viruses are tough beasts. You know, no one has gotten rid of varicella, HSV 1 or 2, EBV. I don't see us solving this problem soon, though I think strategies to improve immune control will be first before we ever get to, you know, and achieving functional cure may happen in the next decade. I think true viral eradication is going to be distant, if never. So I'm going to thank you all. I guess I'll leave you guys to go late into your evening. I wish I could stay longer, but this way maybe I'll get an invitation to come back.
Certainly, certainly. We'd love to have you in person here once COVID subsides in India, hopefully next year.
Thank you, Dr. Brown. Thank you.
Thank you, Gavin.
Thank you so much for having you. Glad to have you here. Great. Dr. Arora, Dr. Chaudhary, if I know it's late for all of you, there
Couple of cases.
there are cases.
I mean, cases, I think Anil would be the best to discuss them, you know. He's got such profound knowledge of hepatology, and your dad is there. So yes. But I really enjoyed the discussion, and if you would let me go, then, you know, I would like to thank you profusely also. It was very interesting indeed.
Thank you.
Thank you. Thank
Yes,
you. So
thanks a lot.
Thank you.
Bye.
All right. We'll, Doctor, if you want, we can do one case, but I guess it's.
No problem.
Yeah.
Ravi can.
Ravi, do you want to present your case to Dr. Arora? That'll be a refresher for you, I think.
It's been 2 years that I haven't presented a case to him. So
I would like to assess him. How much has he been now better?
So please don't give me marks this time. So I'll be sharing a case. Which we had
This
encountered
was
in
more longer than I anticipated. You guys were right. That was fantastic discussion. Thank
Yeah, hepatitis B, the moment you started, is a never-ending discussion.
you. Yeah.
Yeah, so this topic, the word had been spoken about it in a while back in one of the questions. So I'll just discussing a small case this time. It's a 29-year-old male patient who had a BMI of 22 with no significant history of alcohol consumption and no history of diabetes. He was diagnosed to have compensated cirrhosis and on evaluation was found to have Hbsag positive. His ALT was 21, albumin was 3.6 grams per DL, INR was 1.2, and total bilirubin was 0.9 mg per DL. On further evaluation, his HBe antigen was negative and anti-HBe antibodies were positive. His DNA levels were done twice, as Dr. Arora just said a while back, that we need, this is a disease in which the DNA levels can fluctuate, and both times the DNA were not detectable. Further evaluation, a fibroscan was done, which revealed a cirrhotic liver, F4 fibrosis. Upper GI endoscopy did not reveal any varices, and ultrasound revealed cirrhosis of liver with no space occupying lesion. The portal veins were not dilated. Mild splenomegaly was seen with normal IVC and hepatic veins. So this brings us to this pertinent question: in a patient of compensated cirrhosis with Hbs Ag being positive and undetected DNA, whether to treat or not. I would like to have the opinion of the house. I think Russ sir is there, so we can start with him first.
Yeah, you see, if you go by the guidelines, Ravi,
Yes.
most of the guidelines will tell you what do we achieve by antiviral therapy. So if you look at the way the virus replicates right from the point of its entry, where the anti-CP receptors into the cytoplasm, and from the cytoplasm into the nucleus, and from the nucleus down into the cytoplasmic areas, and then replication. The only thing you are acting with nucleoside analog is you are acting at the fag end of the cycle, and you are just suppressing the DNA. If the DNA is already suppressed, so I do not see any point of giving antiviral therapy unless your one reading has missed because of the poor sensitivity of the test. I like to repeat the reading. If they have been consistently normal, I think we will only add to the toxicity of the antiviral drugs rather than giving any advantage to the patient.
Okay. A comment from Mukevar sir.
Sorry, there was an urgent patient call. We were getting too many patient calls, so sorry for that.
I'll go ahead with the presentation. So what do the guidelines say? As sir has rightly said, there are multiple guidelines and all the guidelines have different takes on this situation. However, what I could find is a cirrhosis patient who is compensated or decompensated as per INASL guideline written by sir himself, showed regardless of ALT levels, HbAg status or Hbv DNA levels, antiviral treatment is required. In 2017, EASL published their guidelines, which says again that in a patient of compensated cirrhosis and detectable DNA levels must be considered for treatment if ALT levels are normal. So in this patient, it was undetectable. What do ASLD say? ASLD recommends adults with compensated cirrhosis and low levels of viremia, that is less than 2000 international units per ml. They haven't mentioned specifically whether the DNA was undetectable remains or comes in this category. They need to be treated with antivirals to reduce the risk of decompensation regardless of ALT level. However, the quality and certainty of evidence was very low and the strength was also conditional. If, however, you are following these patients closely, then it should be monitored every 3 to 6 months for the rise of Hbv DNA or a clinical decompensation. And any of the things appears, one should start treatment. Now, what do APASL say? APASL says in a patient of compensated cirrhosis who has a DNA detectable with elevated ALT or a DNA more than 2000 with normal ALT, we should treat the patient or obtain a histology if the fibrosis cannot be assessed non-invasively. So what is the best approach? This was a very elegant study published in 2015 from the Korean group. They had the luxury of following up patients who had low level of viremia in compensated cirrhosis, as the insurance policy in their country does not give antivirals in patients who have low levels of viremia in compensated cirrhosis. So they had around 385 patients, of which 117 were having undetectable baseline Hbv DNA levels, and 268 of them had DNA levels between 12 and 2000. Out of the 117 patients who were undetectable, 61% of the patients on follow-up did not have detectable DNA, and certainly they did not receive antiviral therapy. Only 30% of the patients whom they followed up had low levels of viral DNA on follow-up, but it was less than 2000. And of them, only 7% received antiviral therapy. And amongst the total group of 117 patients, only 7% of them had experienced elevation, that is above the level of 2000, and most of them received antiviral therapy. So when these patients were followed up for approximately 5 years, they found that the group in which the Hbv DNA levels were high with raised ALT had a higher risk of development of HCC as compared to those who had normal levels of ALT but still detectable DNA, as compared to those who were having undetectable DNA, excuse me. And again, these patients who were not given therapy, there was a significant amount of difference between those who had raised ALT versus those who did not have raised ALT. And when they followed these patients and started few of them on antivirals, they could see the in the natural history of the disease, those who had elevations had higher evidence of hepatocellular carcinoma as compared to those who were having undetectable. And when they started antiviral therapy in such one of these groups, they found that the risk of development of HCC significantly decreased. So when they followed these patients, 10% of them developed HCC over the next 5 years. However, those who had undetectable DNA had a risk of 2.2%, whereas those who had low levels of DNA had 8%, and those who had low levels of DNA with elevated ALT had 14%, which was the highest in the whole subgroup. And during follow-up, those patients who were not given antivirals, 13% of the patients developed HCC in those who had experienced DNA elevations. So experience of DNA elevation or having low levels of DNA with an elevated ALT levels were the group who had highest levels of risk of HCC. And only 1.4% of the patients who had maintained undetectable DNA levels had development of HCC, probably due to the presence of cccDNA and cirrhosis itself. The most stark point which I want to highlight from this study was at 5 years, cumulative HCC incidence was 5.9% of the in patients who were started on antiviral therapy. Now, antiviral therapy was given in those patients who had either elevation of ALT and or DNA. So hence, these are the ones who were likely to develop HCC, and still they received antiviral therapy, and the risk was significantly reduced as compared to those who were not given. Now, they also stressed to the point that longer the duration of antiviral therapy and longer the complete virological response was associated with the lowest risk of HCC. So in this patient, we erred on the side of giving the antivirals, probably for giving the benefit of doubt to the patient and for our own feeling of safety. Thank you.
Thank you, Ravi. Wonderful. Thank you, Dr. Arora. So we can just sort of go through some of the questions because I'm sure the audience is eager to know the answers.
I think if you analyze this study properly, there are two simple points.
Yes, sir.
The relevance of HCC in patient with chronic hepatitis B is related to two events. One is the multiplying virus, which is deflected by presence of Hbv DNA in the blood, and second is the ongoing inflammation. Because it is a pleiotropic effect of Hbv, both in terms of integration of the virus into host genome, causing genetic and epigenetic changes, as well as inflammation-induced malignancy. So it is very clear that if you have persistent inflammation and replicating virus, you are more likely to have HCC. So that goes by simple logic.
Right. Okay. Thank you. So we'll just check some questions here. Some reports of anti-HBC false positivity. In the Indian context where the prevalence is so high, I guess the truly occult HB infection is more.
All over India, yeah. 43%, 35 to 43% of our population has anti-HBC positivity. The only relevance of looking for occult HBV is in settings of immunosuppression, organ transplantation, or chemotherapy. Short of that, as of now, it has no clinical relevance.
Right. So we should be vaccinating these patients if they don't have anti-HBS. I think that's the next question. It's pretty straightforward.
In fact, the only protective antibody in hepatitis B is anti-HBS.
Right.
Not core antibody.
Will core antibody affect transplant options? Sure, they will.
Yes. In fact, obviously, the only if you look at the donor liver, which is core positive, and if the recipient is anti-HBS negative, that this is a subgroup of the patient who need a lifelong nuclear NA therapy. That goes with by default.
It's the question by Dr. Amit Gulane, same thing. Nucleoside stopping rule in post-liver transplant recipients with anti-core positive donor. So,
in fact, there has been some data, there is some data published from India also that if you have given immunoglobulin prophylaxis coupled with antiviral at the time of transplantation, if the patient did not have HBsAg positivity at the time of transplantation, if the only indication was anti-HBC, then Dr. Subhash Gupta's group and Dr. Manav Adhan's group from Apollo have shown that you can stop antiviral therapy after 2 years.
After 2 years of transplant?
2 years.
Okay. Do you still monitor these patients, I would imagine? Then
you have to keep monitoring them lifelong. Because if core was the only indication, then you can stop it after 2 years, especially if you have given concomitant immunoglobulin prophylaxis and antiviral right at the time of transplantation.
Right.
That is the caveat.
Okay, Dr. Prakhar Garg, we've answered this. We need.
I have a question, sir. Sir, I was asked this question by one of my nephro colleagues. A patient who has HbSAg negative but anti-HbC total positive and CKD. What kind of dialysis settings? Like they segregate those who are hepatitis and those who are not. So, what is the answer for that?
HbSAg is negative, and if core antibody is positive, you don't need to segregate them. It's only if you have HbSAg positive, you need to have segregation. And in hepatitis C, there is good data, at least from Japan, that there is no need. If you take the standard hygienic practices and standard protocols for dialysis, you don't need to separate out hepatitis C patient on dialysis from those without hepatitis C.
But Dr. Arora, if the patient is anti-HbSAg, HbSAg negative, anti-HbC positive, if there is viral load to some degree, would we be concerned about infection transmission in that case because of the high infectivity of HBV, hepatitis B?
Yeah, it depends on which setting you are talking of. That is precisely the reason, Saurabh, that most of the hospitals, including ours, are looking for NAT testing in the blood donors. In nucleoside acid testing, you can pick up as low as 5 international units per ml of the Hbv Dna. So that can be done either as pooled donor or like what we do in Gangaram Hospital on single donor analysis. So by that scheme, 99.9% of the time you are going to reduce the infectivity. But mind you, even in US, even if you have a NAT testing, there is some chance of either the window period or
I was coming to that
it could lead to post-transfusion hepatitis.
Yeah. There are cases of which are NAT negative, but the transfusion has occurred because the amount of DNA required for transfusion is 3 to 4, and the NAT testing is testing about 4 to 5, I think. So
NAT testing, in fact, there is
NAT is also not completely proof.
The current testing of NAT, which we are doing as an individual, there are two types of sort of NAT testing. One is the group pool testing. That means you take 100 samples, put it in the group, and then see if it is positive, you reject and discard the whole group. We do in Gangaram an individual testing. The sensitivity of the individual testing is 3 times more than that of a group testing. In group testing, the minimum amount of the virion which is picked up is 20 international units per ml, whereas in individual testing, up to 5 international units per ml of virus can be picked up.
Correct.
Okay.
Yeah.
No, great. Thank you. So do we need to do HBV titer a few years after getting vaccinated? HBV titer? I don't know what he meant by that. Anti-HBS is probably what he means.
I think as a rule, all patients who have been vaccinated, the recommendations are 4 weeks after the last dose of your vaccination, you should look for an anti-HBsAg titer. The reason is, if it is more than 10, you are protected lifelong. You don't need to keep chasing the titers unless you have specific condition of immunosuppression. If you are positive once, you are going to be positive lifelong.
Right. No, so is my sort of feeling was immunosuppressed, decom cirrhosis, CKD, we should definitely be checking. Would you check in all comers at your clinical practice? All comers?
No, not if it an immunocompetent person, this. I'll prefer to check it up in all person for 2 reasons. One is you want to see the efficacy of your vaccine, compliance of your vaccine, and the true real world data can be known. Patient, there is no need of doing it immediately, but 4 weeks after the last vaccination, if you test it, I think it gives enough confidence to the patient, and you see your purpose is well served because it is a one-time test in the lifetime. At least one thing you can get rid of once patient has confidence that you have developed anti-HBs antibody.
Got it. Okay.
Any drugs to treat CCC DNA?
I think he mentioned about the German and East European.
CCC DNA, as mentioned by Dr. Robert Brown, is that it is basically, what is CCC DNA? It is a replication competent group, a bunch of DNA which is chromatized. Very sturdy, very difficult to get onto, very difficult to get degraded. So the only way of tackling it, either you have to prevent. So my impression is that the moment the virus enters into the hepatocyte, it converts from a incomplete recombinant CCC DNA to a complete circular DNA. It is an incomplete virus which becomes complete. If you can intervene at that stage, I think the whole story of hepatitis B virus may change. So either by chemical degradation or by epigenetic changes or by interferon, you can tend to degrade. But the problem is how to assess the amount of cccDNA in the body. Then now there are techniques of doing a liver biopsy, and you can even pick up one single cccDNA molecule in 10 raised to the power 5 hepatocyte, but that is all experimental. There is no correlation with the blood cccDNA because not all of the cccDNA is transcribed or translated to produce proteins. It's very difficult to get rid of it. That is the biggest problem in hepatitis B.
Yeah.
Yeah.
So
And
CRISPR technique is one technique, which is the upcoming technique to degrade it and splice it into multiple pieces to get rid of it.
okay. Next is a question, Dr. Smith Kumar Vagasia. HBV genotype when to do? I think Dr. Brown did mention A, B, C, Ds in patients to response to treatment, right? Any thoughts on that?
Yeah, you see, this business of doing Hbv DNA was more relevant when in the era of interferon therapy, because we knew the best results would be obtained in genotype A versus genotype D.
Correct.
But as of now, there is no data to show that there is any relationship between nucleoside analog therapy and genotype. So genotype testing is more of a research tool. In clinical practice, as of now, it has no relevance.
Okay. And there's another question. Chemotherapy with HBV positive, what HBV load safe to start chemo? I mean, okay. Assume you're treating, I would imagine that you're treating with tenofovir or something to suppress.
No Hbv DNA load is safe in chemotherapy.
Yeah.
There are three types of agents which tend to produce reactivation of the virus. We wrote down the guidelines. We published the guidelines as an Indian consortium on management of immunocompromised patient on chemotherapy. There are three groups of the patient: those who have a low risk of reactivation of the virus, like steroids, that is less than 1%. Then you have the group of the drugs which gives you moderate reactivation, 1 to 10%, and then you have a group of the drug which has a more than 10% on the reactivation. Classical example is solid organ bone marrow transplantation and rituximab. So in patients who are having low risk, and if HBsAg is positive, you can monitor them. And as soon as there is a flare or ALT rise, you can give prophylaxis. But in all patients who are likely to have high risk of reactivation, like rituximab, irrespective of HBV DNA, the mere presence of HBsAg or core antibody, you have to prophylaxis them 4 weeks prior to chemotherapy and up to 12 to 18 months, especially in cases of rituximab, after discontinuation of the therapy.
Right. Okay.
That only shows, the reason why rituximab is such a big culprit is that this is anti-CD20 antibody. That means the virus to be remaining in a dormant state, not affecting the human beings, you need to have neutralizing antibody. The moment you kill those neutralizing antibody with rituximab, you're going to have flare. That only shows indirectly that B cell immunity has relevance in chronic hepatitis B viral infection. And if you try to do away with it, you're going to have flare.
Correct.
Okay. Patients with recurrent hepatorenal syndrome, should we stop tenofovir considering that it's nephrotoxic? I guess we did allude to that, but
as I said, as I said that, in fact, in my practice, I have stopped using TDF and I have switched almost all patients to TAF.
Right.
Even it is the same drug. If you can achieve the same pharmacological efficacy at 1/12 the dose, why go in with a bang dose? That is one. The moment you have toxicity of kidney related to liver disease, you don't need to change the dose. You have to go by the creatinine clearance, not because patient has hepatorenal syndrome.
Right. Okay. There's one interesting one, which was going to be our third case, but we did not have it. When to treat acute hepatitis B other than acute liver failure? Any specific bilirubin or INR levels? So guess what? What's your threshold? 3, 4?
Saurabh, I will be surprised to know that there are people in India who do not believe that acute hepatitis B ever occurs. They think, I don't want to name them, they think all hepatitis B, unless proved, are reactivation.
Yeah.
It's very difficult to distinguish between the two. I'm sure you had a case for presentation.
Yeah, that's the thing. So
reactivation versus chronic.
Usual clinical challenge scenario.
Yeah.
Unless in my practice, what I do is I take a complete history, especially of all the risk factors which could have caused hepatitis B, like recent surgery or blood transfusion or tattooing. And then I do a fibroscan, I do an ultrasound, and most of the time you are able to distinguish between the two. Now, the DNA load and the specific type of core antibody with the 19S fragment, this is all theoretical, it doesn't help. So if the patient has a family history of hepatitis B, if there are comorbidities, if fibroscan score is high, I'll prefer to give them antiviral. And even if I have a 5% chance of getting rid of HbsAg, I'll prefer to choose one, because I know in a patient with HbsAg how bad the life is once you're not able to get rid of it. So this is an acute phase in which you already have immune system which is not depleted. If you can supplement it with antiviral agent, I don't mind using it for a short period of time, especially with a drug like TAF, which has no resistance. I'll prefer to use it
in acute exacerbation of hepatitis B. The fibroscan will not be of use.
That's a problem, because
That's
then
a problem.
stiffness is anyways there.
Stiffness will otherwise be increased.
I'll tell you, Ravi was there when we published this data. If you look at the fibroscan in patient with acute viral hepatitis, the maximum fibroscan reading which can go up is 21. If anything more than 21, most likely you have an underlying. We published this in, I think Ravi would remember, Dr. Parveen did this work. If you have a reading of 45, it cannot be because of the inflammation alone. It has to be underlying fibrosis. So up to 21, maybe acute hepatitis, 40, 45, 50, you have to have underlying. But I have a lower threshold of starting antiviral because I want to have twin advantage. You have a hyperacute immune system, you suppress the virus. So it is a win-win situation. What is wrong if you stop it after 3 months? People are so happy, losing their HbsAg. They may have lost the immune system. I don't mind complementing it with antiviral drug.
Okay.
Yeah, that's true.
Fair enough.
Sometimes in clinical practice, the best way is to get a HbsAg after 6 months and tell the patient that if the HbsAg disappears, the treatment has to be can be discontinued.
Basically,
but
that's the best way if you are in doubt.
If you have the stigma of carrying hepatitis B for 6 months, I'll prefer to give antiviral and bring it down within 3 months rather than waiting with uncertainty for 6 months. It's just a possible point.
All right. Okay, so I think there are too many questions, but I think we should take it.
You can answer them.
A couple of
questions are there.
Okay. All right. Let's see something, a different flavor. If there's a pregnant woman with hepatitis B treated with tenofovir becomes HbsAg negative with treatment after 6 months postpartum, patient followed up for 1 year. After 3 years, gets pregnant again and Hep B positive again. What could be the reason? Okay,
see,
so
what I would have done in a situation like this, as we had, part of the discussion with Dr. Robert Brown's presentation is, in a situation like this, I will not be happy with HbsAg loss alone. I would chase anti-HbsAg level. I keep on repeatedly vaccinating them. So unless they have got an anti-HbsAg, you are never sure that they have developed, they have cleared the HbsAg. The reason is the level of HbsAg may have gone down. There would have been some variant or epitopic changes in the HbsAg domain which is not being picked up, and that is precisely the reason it has got cleared up. So you can relax and you can go about your treatment only once you have anti-HbsAg, which is the surest sign of recovery in acute infection.
So your goal is obviously to have more than 10 of anti-HBs, and if it's not, it's going to be vaccinate.
Before I can assure them that they are off the track.
Okay.
But if they have chronic infection, the vaccine may not be of much use.
Absolutely, I agree. It's very difficult, but then you can tell them that this may have temporarily gone down and they have to follow up. If DNA is negative, HbS antigen is negative, I'll stop antiviral at least and then follow them up. You can relax and you can sit back and relax only if you have anti-HbsAg which has developed, which is not easy. I fully agree with you.
Right. Okay. All right. Before starting, okay, that's I think straightforward. Before starting immunosuppressive therapy for any disease, would you recommend HbsAg or total anti-HBC? I guess both.
Both. Yeah, both.
That's pretty straightforward. Okay. if HbsAg positive and Hbv DNA not detected in a patient with decom CLD, won't it cause reactivation and flare in future, hence warrant treatment? Sure, I think we've sort of addressed that. Okay, sorry. I'll just take some more relevant ones here. Okay, patient, this is from Dr. Abdullah Mahmood. A patient of chronic hepatitis B, E antigen positive, taking TDF for 4 years. DNA is negative four times, I guess, 6 months apart, but E antigen still positive. What to do?
Has to be treated.
Treat, I guess.
Treat till
Absolutely.
the antigen
Absolutely.
becomes
Right?
negative.
What do you think? Yeah.
Even this Saurabh, even this business of discontinuation after so-called consolidation period of 1 year, it is pretty controversial. It may be 1 year, it may be 18 months, it may be 2 years. We have had patient, I think Ravi will remember this, was a pediatrician from Aligarh who almost had gone up to the stage of liver transplantation because of the reactivation, believing the principle that E antigen clearance and 1 year of consolidation. Being a pediatrician, you have all knowledge. I believe that unless HbsAg is cleared, I think it is premature to stop it. I'll prefer, especially anybody, if you look at the widening indication and more liberal indication, more than 30 years, comorbidities, fibroscan more than 11, family history of hepatitis B, history of HCC, and metabolic syndrome. All these are indications in which you can be more liberal with therapy. So I'll prefer, unless HbsAg has been cleared and anti-HbsAg is negative, a drug like TAF, it's just like a peanut, such a simple drug, no toxicity. Why not give it? Because even if you have one flare, it can be life-threatening.
Yeah.
Right.
And the flares are more threatening, more life-threatening. Once you stop the treatment, the flares are more severe.
I think all of us have seen that in our individual experiences, that flares can be detrimental and
they can be catastrophic.
Yes. I haven't had personal experiences of transplant unit where I was working constantly. Flares, people are non-compliant. It's just terrible. I agree. Okay. Any role of dual antiviral therapy in acute Hep B failure? Probably not.
Yes. The only indication which we have been using is in subgroup of the patient, as Dr. Shrikant was saying, severe hepatitis, more than 20 milligram bilirubin, rising INR, in which the Hbv DNA does not settle with one antiviral. We had at least 5 patients which required a combination of entecavir and tenofovir in acute hepatitis with reactivation. Other than that, we don't usually need it.
So you would use entecavir with tenofovir both in these
scenarios? In case the patient with acute reactivation does not settle within 1 to 2 days, both in terms of subsidence of the bilirubin or normalization of INR, then as a desperate effort, it is said that you need to have one more suppressive agent, maybe 2 may be acting at a different level to suppress it at a faster pace than one would do individually.
Okay, great. Should we change TDF in patients with recurrent hepatorenal syndrome? I mean, I guess there are thresholds, but we should always change to TAF, I think. But now the hepatorenal is then again decom cirrhosis. Now there is no recommendation in decom cirrhosis, but we all use it, right? So, sorry, I think you're mute. I apologize.
Recurrent HPS, recurrent HRS needs liver transplantation, not TDF.
Yeah.
Up to 15, there is no need of changing it. And if need be, if the patient cannot afford liver transplantation, which is more often than not the scenario in India, then you are justified to switch over to entecavir.
Right. Okay.
Thank you.
Wonderful. I think that was a marathon session.
Marathon session. Yeah.
Thank you so much.
We apologize for not allowing you to present your case. We will present in some other forum.
Yes. Already, sir, I discussed something about acute flare and everything. Yes, sir.
Yeah, we did get some.
Sir.
Because that case was to discuss about acute versus flare, which he has
already been touched, sir.
Yeah,
yes,
already
sir.
been discussed. Thank you. Thank you, Anil. Thank you.
Sir. Thank you, sir.
Thank you all.
Just 1 second. I'll just.
And let me take this opportunity of inviting you all on for our Saturday's webinar on COVID vaccination, immune response. Is it too little or too much? I think it will be pretty interesting because this is the era of COVID-19 infection. We'd love to have your inputs.
So you said COVID vaccination in what population was that?
Immune response in COVID-19, relevance to vaccination.
Oh, okay. Okay.
Very interesting talk. Is the response, immune response too much or too little? And how is the vaccine? I think this is the hottest topic of the day. I'm
Absolutely.
sure people like you will certainly will contribute to that.
Thank you so much. We'd love to join. And
Thank
also next in our webinar series, we have Dr. Suresh Chari talking on chronic pancreatitis. And we'll have a good team of chairpersons, the endotherapy part with Dr. Mahadev, Dr. Roopjyoti Talukdar as a pancreatologist. And we'll also have a surgeon. We are just confirming with them for this. This will be on Sunday, again, 8 p.m. And anybody with gastroenterology, endoscopy, surgery interested, certainly Dr. Arora, any of your fellows are interested, and sir, you're welcome.
Okay. Thank you so much. Thank you, Ravi. Thank you, Dr.
Thank you, sir.
Muktivar.
Thank
Pleasure
you.
to be with you.
Thank
Look
you so
forward
much,
to
all of
seeing
you.
on Saturday.
Yes, thank you. Thank you.
Thank you, sir. Good night.
Bye-bye.
Chandala. Oops.